Today I want to talk about the new VA-ECMO mode, which is basically something which is a really cool feature for the impeller when used together with an ECMO. So these are my conflicts of interest. So I don't think I need to talk too much with you about this because you're all familiar with this concept, the deadly spiral of cardiogenic shock, and how we want to use mechanical circulatory support devices to stop it right in the beginning, to support the patient, to provide tissue and end organ perfusion, and thereby to stop the cascade and save the patient. And one device we can use to do so, and we heard it earlier, is the VA-ECMO, which is an astonishing device in establishing tissue and body perfusion. However, it's not so good at working together with the heart, and that's also something which you might have seen before. I like so much to show this slide. This is from a study we did together with Dan Burkhoff, and it basically shows you that we already in shock do have a very high LV-EDP or wedge pressure as a surrogate in this kind, which then even increases when we put on the ECMO. And fortunately, we can almost normalize it by adding an impeller on top of the ECMO and thereby reducing afterload. And in a previous study, we could even show that this might be associated with better outcomes, with lower mortality. And this work has informed us about the design of a randomized controlled trial, which I will present later on. So one could now say, okay, we have established this concept, we are testing it now, and if we will see that it actually works in the randomized setting, we are good to go. But as always, to every concept, there are opportunities and challenges. So basically adding the impeller on top of the ECMO is an incredible opportunity to optimize the LV unloading, because we depressure the left ventricle, we facilitate recovery. However, the challenge is that this is an immensely complex endeavor. We do not need to manage one device, but two devices, and those two devices also interact with each other. So it gets increasingly complex because we also need to take care of the patient at the same time. Do we need to increase the P level because we need more unloading, but then we might get suction events and hemolysis? Is the heart recovering? Do we get more inflow to the left ventricle? What's the ventilator setting? What's the volume setting of the patient? So this is something which is increasingly complex. And in the past years that our institution took us a lot of effort and time to take care of these patients, to basically adjust both devices to each other. And the VA-ECMO mode now is a really cool new feature of the impeller or the smart assist device, which provides an automatic optimization of the impeller if implanted on top of an ECMO. So basically what you're looking at here is what we normally know from physiology. So the LV pressure rises, then matches the pressure of the aorta, pushes the aortic valve open, and ejects the blood into the systemic circulation. So this is the coupling of the LV and the aortic pressure, so no left ventricular unloading. This is something we do not want to see in a patient who is on ECMO with an impeller, because then the device would be underused. What we basically want to see is something like this. So we do want to see that the LV pressure is below the aortic pressure. We want to decouple the left ventricular pressure from the aortic pressure. The aortic valve should not open in shock patients on ECMO who are actively unloaded with an impeller. And with this chart, I want to show you where we want to be with this. So basically, we want to be between the gray boxes. We do not have too little unloading. We do not want to have too little decoupling so that the valve opens, especially as the impeller only estimates the left ventricular and aortic pressures, and this estimation is not perfect, so we want to stay below a possible opening of the aortic valve. But we also do not want to be too low, because there would be the risk of suction events, and suction events increase in power levels, could then lead to hemolysis, could also lead to direct damage to the myocardium. So we basically want to stay in the sweet spot therein, and the green line is a bit tended towards, basically the algorithm says it would rather not have suction events than have a little bit opening in some circumstances of the aortic valve. That's why the green line, the optimum target for the K factor, K is the coupling factor, is a bit more towards opening than towards suction event. And We have now used this approach, have used this device in several clinical cases, and I assume that you can all have a quick look at this and grasp what this graph means, and then we'll go on to the next one. Or I might go through this with you in detail. So basically, this is one readout of one impeller run in a shock patient on ECMO. So this is over 7 days, and we only got this retrospectively. So at the moment, we do not see this live, and I'll try to go with you through this step by step. So let's look at the first 2 days. So here you basically see that by having the ECMO in, we establish a fairly good aortic pressure. So MAP is always about 50, and there's not so much pulsatility. That's shown here in the second graph. That's the red dots and the red area. So we almost have no pulsatility. We have almost had, and I can tell this to you from a clinical point of view, the ECMO was running high. There was no native heart function. And the impeller was in the VA-ECMO mode. So we didn't do anything about the power levels. We didn't do anything there. That was all automatically adjusted. And you see on the second bar, you see the green lines. And the green line is the optimum level for decay factor. And in the beginning, there are some artifacts, and it was a bit hard for the impeller to get there. But then it managed to get into this good uncoupling zone. So the impeller managed to uncouple LV from aortic pressure, which was not so hard in this instance. It didn't need it to do that much because there was almost no native heart function. So basically, the impeller was running, sucking blood out of the left ventricle. The ECMO was running very high. Then, over the next days, you see that the pulsatility increased a bit because there was increasing heart recovery. Still, the impeller managed to stay in the optimal coupling or optimal uncoupling zone, decoupling the LV pressure from the aortic pressure, but had to do much more work to get there. So it was, as you see there, it was an increase in P level, then a decrease again, increase and decrease. And all this would have been something which previously we would be doing by hand. And to be honest, most of the times we might have been too late or do a bit too much of this or a bit too less of that because we are not as on time as the impeller can be with its readings. And from the clinical point of view, what we observed during these 2 days was increasing native heart recovery. We were able to decrease the ECMO, which was only running at about 4 liters per minute, but still higher than the impeller, which was running about 3 liters per minute. And then during the last days, you now see that almost the pulsatility of the heart normalized. And you also see that the impeller was almost not able anymore to be within this optimal uncoupling zone and was on relatively high levels. And this was actually a time then towards the end we explanted the impeller, explanted the ECMO. And afterwards, when we got the readings, we asked ourselves if this might have been the optimum time point to actually try to wean the ECMO. At the moment, we only get this retrospectively. This is nothing which is shown to you live, but it's an interesting thought. Could this be a marker when the impeller with this VA-ECMO mode is not able to stay in the optimal coupling zone because there's so much, the heart is pumping so much that it's basically pushing to couple itself again with the aorta? Could that be a signal for us to guide our treatment to wean from the ECMO? We have so many more readings from other patients. I selected to show only this one because it's the most informative. We also have signs of patients who do not have any pulsatility and then go to VAD, and I think that might be too much for one talk, so I opted to stop here. But it's very intriguing to think about this. What might we get from this? Not only does this liberate us from doing it by hand, so it creates time for us to actually care for the patient, to do all the other stuff, but it also might be something which can help us in the future to direct our therapies, to optimize our therapies, and it could be a marker or it could become a treatment marker by itself. So at this point, I would like to conclude the addition of active LV unloading might improve outcomes of shock patients on ECMO. However, this is immensely complex to apply in a clinical scenario, and we do have not only opportunities but also risk, the risk of doing too much and the risk of doing too less. And the VA-ECMO mode is something which is very practical in everyday clinic. It can automatically decouple the LV pressure from the aortic pressure and thereby optimizing the LV unloading. And our early experience also indicates that this might something be which we can actually use to treat a patient as kind of a diagnostic signal. Thank you so much.